I wanted to thank everybody for taking the time to join us this morning for our Skilled Nursing Facility Update webinar. My name is Chris Previte. I'm a Director of Healthcare Services at Feeley Driscoll. For those of you who have joined us previously for a similar webinar, just wanted to give a brief update as to the presentation we have given in the past versus this year's presentation. In the past, we were more focused on accounting update as it pertained to skilled nursing facilities. The AICPA had issued a number of accounting standards updates that were applicable last year for the first time: charity care, bad debt, and malpractice insurance accounting. No such standards updates in place this year, so I think that our agenda will mainly focus on the reimbursement side in regards to the federal update and state reimbursement updates, or lack thereof, and plus the current environment where things stand currently in the SNF environment. The last two slides will focus a little bit on some benchmarks, some things we're seeing in the industry in terms of skilled nursing facilities across the state, some of the benchmarks that they're hitting, and then we'll finish with some conclusions and questions. We'll try to keep the webinar brief, 30 minutes or less, to leave some time for questions at the end. But if there are any questions throughout the presentation, feel free to type them up on the screen, and I'll try to read them as they're asked and address them towards the end of the presentation. Okay, my first slide, which is my federal update, Medicare update. This is where a majority of the activity is going to take place on the reimbursement side. As we're probably all familiar, there's not a whole lot of updates from the state side, from the Medicaid side. But in regards to our federal update, our Medicare update, what we have here on the screen is the fiscal 14 final rate adjustments, as well as we'll discuss a little bit on the proposed fiscal 2015 rate adjustment. CMS issued in May a proposed rule outlining what some of the payment rates will be for fiscal year 15, and we'll discuss some of the changes from 15 to 14 as well. What you see on the screen here is a comparison of fiscal 14 rates as compared to fiscal 13. In fiscal year 14, the net market basket update reflects a 2.3% market basket update, less a half percentage point productivity adjustment, which was enacted as part of the Affordable Care Act in 2010, as well as a half percentage point reduction for forecast error correction. Now, CMS is required to provide a market basket forecast error correction to SNF providers whenever the market basket increase differs from their projection by a certain amount. And that actually can take place in fiscal 14, which is why that half point adjustment impacts the current market basket rate increase in 14. Overall, the increase was 1.3% in fiscal 14, and when you kind of put that into perspective and think about sequestration, which we'll look at a little bit on the next slide, the overall increase in the market basket rate of 1.3% does not even account for, it's completely wiped out by the 2% reduction in sequestration. So you can see the impact just alone in CMS on the federal side from a rate standpoint. Now, in May of 2014, proposed rule 1605 outlined a proposed increase of 2.4%, a market basket increase, which would be offset by a 0.4% productivity adjustment. So a net overall increase of 2% in fiscal 15 is what's being proposed. And so as you can see, that 2% increase in 15 is 0.7% higher than the fiscal 14 Medicare increase. Now, as I mentioned, you can see we just laid out some of the urban and rural rates listed in this chart below. On our next slide, slide 4, when we discuss the wage index adjustment for fiscal 14 and fiscal 15, there's actually some activity in fiscal 15 that should positively boost the wage index adjustment. And when we look at 2014 and the impact on the wage index, and particularly the labor component, there was this 69.55% the SNF federal rate based on a base year of 2010. Now that's actually an adjustment in fiscal 14 to the base year rate, which was previously 2004. And again, this is in regards to the labor-related share of the standard rate. An increase to that labor-related share will decrease payments to skilled nursing facilities that have a wage index less than 1, but it will increase the payments for those with a wage index greater than 1. So that's the impact, and as you can see, we laid out here towards the bottom. I actually cut off a little bit the mass area wage indexes by county. The majority of the counties do exceed 1 for final in 2014. What it actually is cut off there a little is the mass rural rate, which is 1.36 versus prior year of 1.35. And then on the bottom of this chart, again, I apologize for it being cut off, is the Rhode Island rate, which was 1.05 versus 1.07 last year, so actually a slight decrease. But in May of 14, CMS actually did propose some changes to the wage index in an effort to mitigate some of the potential impacts for providers. So CMS proposed to implement a 1-year transition with a blended wage index for all providers, and so really what we'll be looking at here is the wage index for each provider would consist of a blend of 50% of the fiscal year 2015 wage index, which is proposed, I'll go over in a second, and 50% of the wage index using a revised OMB delineation method. And you know, as we know, back in 2013, OMB issued a bulletin which contained changes to the delineations of the metropolitan statistical areas and micropolitan statistical areas in the combined statistical areas. So what happened in this regard with regard to those delineation changes, CMS was proposing revisions to the wage index based on the newest OMB delineations for fiscal 15. And so it looks like this proposal will come into play in fiscal 15 and will impact your wage index. And the way CMS is at least proposing to implement that is using a blended, 1-year transition blended wage index rate, which should help some of the burden for fiscal 15. But overall, in regards to the fiscal 14 final wage index, the rate change, they ranged by county, very, very minor, minimal increases or decreases depending on the geographical location, as opposed to the changes from 13 to 14 were actually a little bit more significant. The RUGS 4 system, which has been in place since October 2011, there's no change in that regard. The RUGS 4 system, I think we're all aware, increased the number of case mixed groups from 53 to about 66, and so that system is still in place. There's no potential change to that anytime in the near future. And then last, the MDS 3.0 is still in use. This was implemented in 2010 as part of the Affordable Care Act. So the MDS was updated from 2.0, and at the time there was, I think, a delay in the implementation of that, as there was a group of software that was not readily available to convert the data, but that didn't get implemented until 2011. But overall, those are our area wage indexes down there in that graph below. Just to continue on the federal update, we look at, I'm going to jump ahead, the work plan is that last slide, but we look at the Budget Control Act of 2011. No change here. The Budget Control Act, really where sequestration came out of, the 10-year plan, which was to reduce the federal spending by $2.1 trillion. One thing we're seeing in the industry in regards to the sequestration adjustment, which really does take place for Medicare payments beginning in which began in January 2013, was proper accounting for the payments or the lack thereof or the reduction in payments in January 13. For those accounting folks signed in today, what we're really getting at here is if you have your billings, your AR system, and your AR system really needs to be adjusted for the payment reduction, which would remove any uncollectible portion of the Medicare AR. There's been discussion on whether this is a contractual write-off versus a bad debt write-off. However, if your system is not updated, what happens is your billing system bills out the claim at at its full gross amount, and your accounts receivable system writes off your contractual allowances and or bad debt allowances based on your historical prior information or whatever methodology that's used. If that methodology is based on history and it's not updated for the sequestration 2% payment reduction, what happens at the end of the day is your accounts receivable is essentially overstated by this 2% sequestration adjustment that was never updated in your system. It's not necessarily something that's very easily calculated or very easily determined from an accounting standpoint, because most accounts receivable systems are updated based on historical data or payment on account factors, and we look at collection experience. However, we know that we have no collection experience in regards to the reduction, and therefore it needs to be updated or implemented retroactively to update those accounting systems. And so it's something that we're looking for on the accounting side when we do review our skilled nursing facility balance sheets, particularly surrounding the valuation of their accounts receivable. But as I mentioned, that 2% reduction to Medicare payments that began in 2013 essentially wiped out the rate increase, any federal rate increase to nursing homes, particularly in fiscal 14, where the overall net increase was less than the 2%. So there's actually a decrease in your Medicare, your Medicare service. The last, the last item is just a quick summary of the OIG work plan. OIG every spring issues a study or a summary of their work plan. In particular, we pulled out some of the issues that impact skilled nursing facilities. In a lot of what the OIG work plan is based off of is in 2009 they did a study. They found, I think that it was widely publicized, but they found that about 25% of all claims that were billed by skilled nursing facilities were billed in error. And there was about $1.5 billion of inappropriate Medicare payments. And so what the OIG did in their work plan was to continue to look at variations within SNF billing practices. So they wanted to identify any questionable billing patterns, to prevent any erroneous billing or anything along those lines in the industry. So that's one of their focuses. It's still one of their main focuses, in 14 as it has been over the past 5 years or so. One of the other areas, billing areas that the OIG will focus on is Part B services provided to nursing home residents during stays not paid under Part A. And so what, for example, stays where benefits were exhausted but still being billed for and paid, or there was a failure to meet the 3-day inpatient stay requirement under Part A. OIG is still focusing their, kind of their work plan in that regard, and they'll look at those billing practices there. In 2014, in the 2014 OIG work plan, there's a quality of care and safety that's an ongoing area of focus for the OIG, so they'll continue to determine whether state agencies verify corrective plans for deficiencies identified during surveys. So I think that where this can be a big issue or a big area is when if there are issues identified in a survey that there's no corrective action plan in place, the OIG will continue to look to focus to make sure that that is in place. In Massachusetts, in the non-for-profit world, if you think about corrective action plans or areas of deficiency, the Attorney General's office spends a lot of time making sure that nonprofits in Massachusetts abide by their regulatory rules and requirements, and they make sure that these are implemented. The IRS does a great job in the 990, in the Schedule O, particularly since 2008, where they require significant disclosure narrative of these particular areas in regards to controls from a finance perspective. The OIG is trying to take the same approach. There's no formal current formal documentation requirement, and a lot of times these things come about after the fact, where the OIG comes in to take a look at things in some of these facilities. But when reading through the work plan, one of the other things the OIG is focusing on is when they found that I think it was 90%, or it was about 90% of nursing homes employed at least one individual with a criminal conviction. So they spelled it out in their work plan that they'll continue to monitor the effectiveness of the program for national background checks for the long-term care employees. And then the last item kind of that I wanted to focus on here is that the OIG plans to review the extent to which the Medicare beneficiaries that are in nursing homes are hospitalized for conditions thought to be manageable or preventable in a nursing home setting. And so, this is has always been a touchy area, and so the OIG realizes that and focuses on it in their report. Okay, moving off from the federal update, we'll get a little bit into the state update, and from the state standpoint, and we'll move on to the current environment and what nursing facilities or skilled nursing facilities, particularly standalone skilled nursing facilities, some of the challenges that they're facing in this environment, and what are some of the things that skilled nursing facilities can do, to mitigate these challenges. So when we look at the state rate update, I think we're all well aware there has been no changes in the standard rate component for fiscal year 14 for the final rule, and it's been about 6 years in that regard for no updates in the standard rate. So 2009 through fiscal 13 has been the same standard rate. The bed hold payment, the bed hold program in Massachusetts, which is not it's not a program governed by federal law. It's a state-by-state program, but the Mass Health bed hold programs pays nursing homes, in this rate. You can see, I believe last year the payment was $80 per day. It's disclosed that the payment will be a minimum of $30 per day in fiscal 14, but they pay the nursing homes to hold a bed open for up to 10 days during absence of one of the patients in the nursing home until the resident returns. The goal of the bed hold program is to protect the residents. Any of the nursing home residents who suffer from dementia or certain other ailments, they would potentially have to move if they left the facility and there was no bed hold program in place. And so that's really the goal of the program. Without it, Mass Health wouldn't pay the nursing home for the days when the resident's away. The nursing home's hands would be tied to almost to fill that bed as soon as possible to make up for that shortfall. The pay for performance funding was $2.8 million in fiscal 14. Now this is a similar amount as paid in prior year, and then the user fee provision for Class 1 nursing homes, standalone homes, is $18.41 with an add-on provision of 98 cents, of almost $1. And put that in perspective, last year that the add-on provision was $3.20. But again, no change to the implementation of that provision, just changes in the actual rates. And then overall capital payments rates didn't change on the state side. So where do we stand today in regards to nursing homes and the industry in general? Quick high-level overview. Nationally, there's a deficit of about $8 billion. Where we're saying the cost of care exceeds the reimbursement. So that gap, that funding gap, in particularly in Massachusetts, is worse than we would see nationally. $350 million in Massachusetts of a funding gap, of $37 per patient day in Mass. When you try to boil it down to per patient per day, that $37 are almost $40, and this was, as calculated by a survey of Mass Senior Care organization. It's a pretty large gap, and when you look at Massachusetts as compared to the rest of the country, it's determined that Mass is as the fourth largest gap, as the fourth largest gap in the country. It's about $1.7 billion. And Deval Patrick did propose a $21 million cut in Medicaid spending. Now, nursing homes are currently lobbying for actually an increase in $27 million for in reimbursement. That's really, when you think about it, a $48 million change from Governor Patrick's proposed decrease. What does this all say, really, for the industry? Why is the nursing home industry struggling in some regard? There's more widespread use of outpatient services. Nationally, there's been a decline of 7% since 2000. So over the past 15 years, when I say decline of nursing homes, I think in the past year there was anywhere between 4 and 6 homes that closed over the past year, just due to sustained losses and lack of cash flow that these homes are suffering from. Massachusetts' decline in nursing homes is 20%. So when compared to the national average, 13% greater than the national average in 2000, when there was 500 nursing homes, standalone nursing homes, we're down to 420. Now, part of that is because of consolidation in the industry, but also because of the widespread increase in assisted living, home health type facilities that that are kind of flooding the nation. The lack of funding, what it's impacting on a facility by facility basis is a lot of nursing homes. When you read through the surveys and you're looking at the surveys, average age of plants is growing. What does that mean? It just means that nursing facilities don't have the cash flow or the funding to put into their physical plants. And so as their physical plant gets older, there's no facility updates, and that directly impacts your quality of care. Without the technical updates to IT, the physical room requirement updates, there is an indirect impact on quality of care. So these are just some of the things that nursing homes in Massachusetts, in particular, across the nation, are struggling with. And so how do we solve that problem, and what's next for nursing homes? And there's really a number of things that nursing homes can do. In particular, cost cutting, being the first. Aside from any of the other items listed on here, nursing homes need to get a handle of their own cost. Without reducing the quality of care or hurting your patient's stay. How can we cut costs and at least make up for the 2% sequestration, just to stay even from prior year, but even more so to stay in the red. We talk about, we look at nursing home census, we look at where the referrals come from, and more than half of the nursing homes in Massachusetts were losing money in 2014. Standalone nursing homes, and the reason being is that the majority of their funding comes from Medicaid. The facilities that are losing money have a high have a high payer mix of Medicaid, and we're talking 85, 86% Medicaid, 10% Medicare, 4% private pay. As the payer mix shifts to shorter-term care services, where Medicare and private pay can come into play, in Medicaid service decreases slightly, facilities are able to show positive figures, positive cash flow, and keep numbers in the black. Now, nationally, when we look at payer mix by nursing homes, on average, and I believe I have this on the last slide or second to last slide, the Medicaid payer mix was anywhere between 60 and 70%. In Massachusetts, it's a little bit higher than that. And so when we look at Massachusetts and try to determine why Massachusetts facilities are struggling more than they are nationally, that's part of the reason there. Strategic alliances is one area that, when we look at consolidation in the current industry, the ACO and MCO environment, do facilities have the resources in place to make a strategic alliance or consolidation with a larger, system? It's something that I know more and more owners of for-profit and non-profit facilities are considering in this environment. That would include contract negotiation, and it also directly impacts the quality of care outcomes. And I mentioned some of the quality of care outcomes that the OIG was focusing on, and as well as some of the quality of care outcomes that are required in the ACO environment. We look at shared savings clauses, where you meet certain quality of care incentives. You are reimbursed for X%, depending on the contract, X% of those clauses. And so these are some things that nursing homes need to start considering in this day and age. The information technology is always an item that needs to be funded. When we look at the IT environment, and we look at from the accounting system standpoint, from an internal control standpoint, from a billing standpoint, if your information systems aren't up to date, there's going to be billing errors. It's going to hurt cash flow in the future, and those cash flow hits that happen, under audit or on a one-time basis, are too steep a lot of times for facilities to overcome. And so, by keeping up to date in your systems and investing in those things, we can help at least sustain some of those issues. Again, more and more, I believe I mentioned earlier, nursing homes are looking into other business lines, and you see more and more homes opening up an assisted living facility in order to it accomplishes a number of things. One, you have a referral base that you can control. You have the ability to save costs or cut costs by shared facilities, kitchen facilities, or cleaning staff, if the assisted living facility is attached to the nursing home or at least nearby. But again, you have higher payers, in different payer mix in that arena. The home health arena is another arena where, as the need for long-term care changes, home health is is a growing industry, and it's something that nursing facilities are really looking into. And I had mentioned hospice programs and subacute care as well in regards to trying to shift that payer mix from Medicaid to Medicare to help kind of sustain some of this this cash flow drain. I do have a few questions before I get into some of the benchmarks that are up on the screen. One of the questions is in regards to the chart on slide 4. We'll be sending that out. That chart was answered. It was cut off a little. We apologize for that. And then we have the bed hold. A comment regarding the bed hold is that the Massachusetts is still paying the $80, so the decrease was not implemented. So the proposed decrease of the $30 that I had mentioned was not implemented, and Massachusetts is still paying the $80 currently. That was being paid in fiscal year 13. So thank you for that comment. But just to wrap things up in regards to the current environment and how things impact the freestanding nursing facilities out there, as well as some of the non-freestanding. And I hate to say only the freestanding facilities are struggling, but they are struggling more than those facilities that are involved with larger systems and that are able to more easily save or cut costs. Some of the benchmarks that we look at, some industry-wide benchmarks, and we pull this data. We pull this data from all facilities across Massachusetts, all sizes, and so it's not by any geographical location. It's Massachusetts as a whole. But there is still a decline in occupancy levels. We're here in 2014, and there's been a slight decrease in occupancy year over year over year, and that's caused by the expanding choices for the elderly and for kind of lack of updates in reimbursement rates and the closing of some facilities, which forces some of the elders to move to alternative methods. We look at days cash on hand. This number it's really pretty flat. It looks like it's up from prior years. I think there's a few outliers in the figures that we look at, and this does include all facilities, even larger facilities part of a system. But average days cash on hand is how many days can the nursing facility survive without receiving $1 more of reimbursement, without collecting $1 of their accounts receivable, but still needing to pay all their bills. So your average days cash, and this is operating, operating cash. We're discussing no restricted money for those nonprofits, was about 25 days. And so what that says is, on average, your nursing facility can survive a little bit less than 1 month without receiving any additional money. Ideally, that number should be around 60 days, which is real healthy, strong average. Average days cash. That's 2 months of cash. Accounts receivable days, which is the time it takes to collect outstanding AR balances. Average days of 42. When you think about ideally, what is the ideal ratio in this regard? It's 30 days is 1 month if you think about your normal payer. But in a lot of instances, your payer in these facilities are either Medicaid or Medicare, some private pay insurance, as well as private pay individual as well as insurance. And so the average days of 42 days takes into consideration, what that says is that it takes us 42 days to collect our outstanding AR balances. What could be an indication of growing AR, and we do see this trend increasing, is one of the things I mentioned earlier, which is not properly valuing your accounts receivable or adjusting your internal systems for contractual allowances or bad debt allowances, particularly for sequestration. And we may see this average days increase in 2015, and when the data comes out for 2014, you know, just based on the fact that, you know, some accounting systems may have a growing balance sheet of accounts receivable, but you know, without a concurring increase in your allowances and reserves. Also, if there's changes in reimbursement and payer mix, will affect this ratio. If Medicare pays on average in 60 days and Medicaid pays in 30 days, as your Medicare payer mix increases, your average days is naturally going to increase with that. And then on the last slide here, 4 more ratios, things we look at, you know, in the industry is what debt to equity, which measures how leveraged the facility is in its ability to pay any additional debt. Industry averages 1-to-1. And what we've seen here is, you know, decreasing ratio, which is good. You know, we're not seeing leveraged, you know, facilities leveraging themselves. But what that means is that just there's less new debt, and when there's less new debt, it means facilities are not going out to banks, not applying for new debt to do facility improvements or add-ons, and, you know, working with what they currently have. So we're not incurring any new debt to cover current cash flow needs, but we're also not, you know, obtaining any new debt, either because we don't have the credit to be able to, or 2, we don't have the you know, cash flow projection that would allow for increased debt for increased improvements and capital improvements in your facilities, or increased equipment. Your operating margin, which is the profitability from the facility's primary source of revenue, you know, 1% margin. When you think about, you know, this is on average across all facilities. It's been about around 1% margin for the past 4 or 5 years. However, as I mentioned earlier, I think that margin is carried by some of the larger facilities in the state, you know, where their margin may be 5 or 6%. Because more than 50% of the facilities in Massachusetts are actually losing money, so they would have a negative margin. Average payer mix in Massachusetts is, you know, you can see it there. This was, again, this is the data that we use, is always 1 year outdated. So we, you know, we'll update this chart next year when the information is released. You can see Medicaid is at 62%, Medicare is at 12%, and then private pay and other, including MCO type arrangements, are at 26%. As that payer mix shifts, or if reimbursement changes from any of these payers, that's going to directly impact cash flow. And then the last ratio that we're looking at here is the cost per resident day, which measures the actual cost to run the facility per resident day. And what this helps put into perspective is, you know, the average cost was approximately $25 per day, $255 per day per patient to run the facility. And when we looked at the funding gap earlier, particularly in Massachusetts, the funding gap was about $37 per patient per day to run a facility. And so when you think about, you know, if the cost is $255, reimbursement is not that, you know, it's not up at that level. It's really difficult for these the nursing facilities to turn a profit and sustain for the future. So with that, I want to thank everybody for joining us today. We will be sending out the presentation for your following today's presentation. If there are any future questions, you can email me. My contact information is right here on this screen here. Be happy to answer any questions via email or take any phone calls as well. So thank you.